Wright State University, which means I learned under Drs. Gentili and Cowan, who you all probably are familiar with from this. And you'll notice they're listed at the bottom of my screen as editors to this handbook, whereas the place I get part of my approach for today. So I wanted to cite that for you. So today we're going to be talking about differential diagnosis, and we're going to do a brief overview and then go through a couple of cases. So a differential diagnosis is what Dr. House and his team does. If you watched that show back in the day, I promise there's no lupus today. But a differential is a list of conditions that might cause a person's symptoms, and is an organized way to think through the possibilities and our next steps. So this is a how doctors think kind of slide, and it's how we kind of come up with a differential. We consider different body systems like the cardiovascular system or the neurological system. I've also added dental and sensory here as subsets, as they might get lost in sort of the broader context of systems. We also consider various causes of different behaviors and disorders, like infectious or toxic. Here you also notice something called idiopathic, which means spontaneous or unknown cause. For example, some cases of autism spectrum disorder are idiopathic. We don't have a particular genetic cause or anything for those cases. You'll also notice iatrogenic at the bottom of the list, which means caused by medical treatment or testing. So maybe if you're taking too much Tylenol, you can actually cause a headache, and that would be iatrogenic. So it's difficult to talk about differential diagnosis without talking about evaluation. And the type of evaluation that is often very helpful is a biopsychosocial evaluation. So here I've kind of listed some things that we're often going to consider in cases like we discuss here in this forum, complicated cases of behaviors often, or different things that children with multiple diagnoses are going through. So just as an example of how to get to a differential diagnosis, we're going to consider the 65-year-old male who presents with chest pain. So you're thinking about all of those body systems and all of the causes, and you're coming up with a list of potential conditions. So I hope everybody is thinking heart attack. Chest pain in a 65-year-old male should trigger that thought. And this time we're also considering COVID, right? Because it has to do with your chest. So we already have a couple of different systems up there, cardiovascular and pulmonary. And you will notice some other systems like gastrointestinal or musculoskeletal are up here. We want to consider both serious things that this chest pain could be and very common things this chest pain could be. We also include the more rare things in our differential diagnosis, but we're going to use this list to help us narrow down what to do. So this is kind of a differential for chest pain. It's very short. There's much more that it could be, but this is just an example. So let's move on to a chart that gives us some different behavioral presentations and what the differential might be for those. So this is a really helpful chart, and we're going to use it as we go through a couple of cases. But let's consider one of them. So a person won't sit down. What could that be? So this chart kind of helps us with a start. It could be that they're pacing around because they feel restless due to a side effect of medication or anxiety. Maybe they have pain and they don't want to sit down. Maybe they have pain in their back or their hips. Or maybe they're actually trying to avoid sleep. Maybe they have nightmares or something, and that's why they won't sit down. So this is a start, and we'll come back to this chart as we go through our cases. So Mary is a 17-year-old female with a history of intellectual disability, depression, and anxiety. And she presents for assessment of mood cycling, episodic agitation, and head banging. So let's look at head banging on our chart. We noticed depression, headache, dental problems, seizure, ear pain, sinus problems, or an itchy scalp might be reasons for head banging. So let's learn a little more about Mary. She has decreased appetite and has lost approximately 2 pounds in the last week. She's been having episodes of crying, which appear to be random. And sometimes when her family or teachers try to intervene in the head banging, she's biting them. Some context, Mary's family had moved about a year ago, and she changed schools because of that. It's reported the transition went really well after just sort of an initial small period of being upset about the changes. But about 2 weeks ago, she began banging her head on walls and tables, both in the home and at school. Her medication includes fluoxetine, quetiapine, and buspirone. And her depression and anxiety has been stable on these medications since just after the move. Her medical history includes gastroesophageal reflux and allergies, but she doesn't take any medications for those at this time. So let's consider what might be going on with Mary and create a differential for her. So we're going to go through this biopsychosocial evaluation and list out some different things that could be going on. So as we consider her history, we consider both her psychiatric and medical history, and that gives us a few options right at the start. We're also adding bipolar disorder here just because of the mood cycling. We want to consider that that's a possibility. Other things that we want to consider as we look at biological causes, and as we think back to her chart, we might think of sinus infections, headaches of various causes. We might think about, is she taking her medication correctly? Does she have dental pain or another injury? And maybe a rare cause of headache would be a brain tumor, but definitely very serious, so we want to include it here. As we move through her psychosocial evaluation, we think about the move and the changes she went through, and we might think about grief over losses of friends or caregivers, or new trauma or bullying. We also think about her new environment, and is it different than the school she was in before? And could she be overstimulated or understimulated? So that's part of what's on our differential diagnosis. Certainly not a complete list. I'm sure you can think of more things, but we'll use this to kind of guide our evaluation. So we definitely want to get other input. A lot of these things could be evaluated by a primary care physician. So we want to have her go to see her doctor. We also want to have her see her dentist. She missed an appointment during COVID because the dental offices closed down. So now she's able to go back. So they're going to reschedule that. You see, I've also listed a couple of other tests here. Do we want to get some sort of head CT or MRI to check for a tumor? Or do we want to get an endoscopy to see if her acid reflux is acting up? Well, the brain scan can be pretty scary. That's definitely a rare thing. And we can get more information from the primary care physician about whether that's needed. Same thing with the endoscopy. The symptoms don't necessarily match GERD all that well. So we might take those off our list for now and see if we need them later. So what happens when she goes to the primary care doctor and the dentist? Well, at the primary care visit, everything went fine. There was nothing significant found except that Mary was really hesitant to open her mouth. So that makes the dental exam really important at this point. The dentist ordered x-rays and found that her wisdom teeth were about to come in. So that's new, could definitely cause headache and dental pain. So we need to get that taken care of. So that we may have found our answer here. And we did. The surgical procedure was scheduled, went really well. And after she recovered, the head banging and her other symptoms resolved. So that's an example of how a differential diagnosis can take us through what we need to do next and what we need to consider. So let's try one more case here. We have James. He's a 13-year-old male with a history of autism spectrum disorder, depression, ADHD, and intellectual disability. He presents for evaluation of some odd behaviors. James has been more withdrawn recently. He spends lots of time in his room, and he is seen muttering to himself as he rocks really vigorously. Now, he's rocked before, but not this intensely. So let's look at our chart again to maybe start our differential going. Intense rocking might be a sign of visceral pain, headache, depression, anxiety, or medication side effects. So we're going to keep those in mind as we learn more about James. He often seems not to hear others when they talk to him, and he hasn't been participating well in school. And as his family tries to hug him, he often swats them away, even though he usually enjoys hugs. He's been a picky eater in the past, but he's not eating very much right now. And mom has this particular concern because she has caught him with his hands down the back of his pants several times, and she's not loving that. But these symptoms are kind of intermittent, and so it's a little confusing. He lives with his parents and his older brother, but his older brother recently started college and lives on campus. And during COVID, his maternal grandmother, who is usually a big support for him, has been around less often and more at a distance. So he's mostly nonverbal, and he does have a history of aggression when he was younger, but he hasn't had any aggression in the past few years. And his medications include clonidine, fluoxetine, and aripiprazole. And both fluoxetine and aripiprazole were increased about 6 months ago when some of these symptoms first started. He has no other medical history. So as we think about his differential, we're going to go through the biopsychosocial evaluation again, and we're going to think about what might be going on for him. So we list those diagnoses that he already has, and we add psychosis. That would be really rare for a 13-year-old, but he's muttering to himself. And there are several other things that might point to that, so we have to include it. I also remember back to our chart, we have side effects of medications listed. So I think about his medications, and we're going to put dizziness on here, stomach upset or pain, and headaches. And we also remember that stomach pain was on our list as well. In this transition time, he's a 13-year-old, so he's transitioning from preteen to teen. Lots of things happen at that time. So we need to consider kind of normal changes as a teenager. And do we need to provide psychoeducation or different routines for them to do? We're definitely considering all types of pain. I know you guys may be thinking about abuse, especially since he's rejecting hugs and spending a lot of time alone. But remember, he's gone through a lot of changes in routine. And he may not have the supports that he used to with his brother and grandmother being more distant now, but maybe they helped with coping mechanisms. Or he might just be bored. You know, he has fewer activities now because of COVID, and he may be expressing that. But I also have to wonder, is he hiding something? Is that why he's in his room all the time? Is he using drugs, or does he have some sort of eating disorder? So we take this evaluation, and I really want more information. So the family and caregivers did a behavior chart, including mood, activities he's doing, people he's around, what he's eating, when he's going to the bathroom, and when he's taking his medications. A primary care appointment is always something that we want to consider. He did have a dental appointment recently, and that was fine. So when we did the behavior chart, mom noticed that he was spending a really long time in the bathroom sometimes. She's not sure what that's about because she doesn't want to invade her privacy, but she thought we should know. And she's right. The PCP found that his abdomen was distended, and James was not about to allow her to get near his belly. So she did an x-ray and found a colon full of stool. So that's great. I mean, not great for James, but we might have an answer there. So Miralax was ordered for a clean out, and he had a few rough days, but after the constipation cleared, he really went back to himself. We're not quite done there though, because we have to know what caused the constipation. That's part of the differential. So we think about his habits and routines, set up a toileting routine, but we also want to take a look at his medications. They can each cause or contribute to constipation. So we definitely want to reevaluate his medications and what he needs at this point. So some of the takeaways from building a differential diagnosis: remember your biopsychosocial determinants of illness and behavior. You definitely want to consider serious and common problems and use them, use your differential to decide what to do next. Medical and dental evaluations are important to get regularly. Pain and the ability to communicate, or how people communicate, is always something that we want to consider. And especially with medications and treatments, more is not always better. So consider the consequences of that. So hopefully you have a little bit of a better idea of differential diagnosis now. And thank you for your time and for listening.